Hi, and welcome to today's episode of Feature of the Day. Today's feature is about something that we don't usually encounter in a clinical practice, but in my experience of working in a government institution, I have had these cases probably thrice or four times in a year. So, the topic for today is about raising a bit of awareness amongst obstetricians about congenital diaphragmatic hernia. Today is Congenital Diaphragmatic Hernia Awareness Day, that is today on 19th of April. And in this, I'll be talking about the obstetric and slight bit of fetal medicine aspect to it to enlighten ourselves about this. This is not completely a pediatrician's domain. This is something that even we can have an insight on about the prognosis, about what to tell the patient and the relatives. And I believe that is the reason I chose this topic today. So, what is congenital diaphragmatic hernia? For all the basic knowledge that we can talk of, it is a maldevelopment. It is a development of the diaphragm that has been impaired, because of which all the abdominal contents, which includes the stomach, the intestines, and often even the liver, come and occupy the space into the thoracic cavity. Now, very often this is seen on the left side, and which is why the lung on the left side gets compressed. The lung and the heart are then pushed onto the right side, but the right lung is generally not compromised. It is well in function, but the problem is with the left lung, which gets compromised completely. Because of this compromise, there is pulmonary hypoplasia, especially of the left lung and also a bit of the right lung. And owing to this, the vascular development, the pulmonary vasculature that is developing is dysfunctional. It leads to pulmonary artery hypertension. So, in this image, as we can see, that this stomach and the liver has also come into the thoracic cavity, and the lung has been pushed completely over there. Even the heart, if you can see, has been pushed onto the right. So if this was a midline, this has been pushed to the right of the midline. This will eventually lead to pulmonary hypoplasia, that is, the lungs stay hypoplastic or small, and pulmonary artery hypertension. These are the two main things that will happen. So, what can we do as obstetricians for this? Well, in the antenatal period, and a modality of ultrasound is to check for the lung to head ratio of the fetus. So this is done around 24 to 26 weeks of gestation, in which we check the right-sided lung, the lung that is fairly uncompromised in comparison to the left lung. So we check the area, we check rather the circumference of that lung, and then we compare it to the circumference of the head. Now, if that ratio is above 1.35, this means that the lung is almost 1.35 the times of the head. It is generally said to have a good prognosis with a 100% survival rate. So there is a survival rate of almost 100% in this scenario. Whereas if the lung to head ratio is less than zero point 0.6, and by less than zero point 0.6 it means that it is almost half the size of head. If the right lung is almost half the size of head, and why are we considering the right lung here? Because after delivery, the right lung is the one that is going to ensure the oxygenation of the baby is kept well, because the left lung is hypoplastic and it probably is never going to attain its original size. And hence, the right lung ratio is considered here. And if the ratio is less than zero point 0.6, it almost has a completely fatal outcome. Also, what can be done antenatally is a fetal therapy procedure that we call as FETO. FETO is fetal endoscopic tracheal occlusion. In this, we use fetoscopic, and basically fetoscope is something like we do laparoscopy in adults. So in this, we insert a fetoscope which is almost 3 mm in size. 3 mm is very tiny. We insert it inside the uterus just like we insert a needle for amniocentesis. In that, we take a balloon. That balloon is inserted inside the trachea. The trachea is occluded with that balloon through this fetoscope that you can see over here. Now, what this does is the lung is continuously producing fluids. It is producing interstitial fluids. It is producing mucus. Now, the outlet to this, obviously, as you know, that the amniotic fluid is also maintained not just by the urine of the baby, but also by the lung fluid that comes out from the mouth of the baby. Now, when you are going to obstruct this trachea after this procedure, that fluid will stay back in the lungs, and this will help the lung, especially the left lung, stay inflated, and will to some extent push the herniated abdominal contents back into the abdominal cavity from the thoracic cavity. This is to be ideally done around 26 to 30 weeks of gestation, And this plug then has to be removed at around 34 weeks of gestation, because this plug is known to ensure that the surfactant that is produced, that is required for the baby to survive after delivery to avoid respiratory distress, that production is also reduced because of the bad effects of this tracheal occlusion on the type 2 pneumocytes. So this is removed around 34 weeks to offer the baby at least 3 to 4 more weeks for normal surfactant production and for whatever little development respiratory distress, to avoid respiratory distress after delivery. So this is called as FETO, that is fetal endoscopic tracheal occlusion or fetoscopic tracheal occlusion. After this is done, the lung size is somewhat ensured that it can be kept in the normal range. Then the baby is delivered between 37 to 40 weeks. There is no point of delivering this baby before term. When the baby is delivered, do not give that baby bag and mask ventilation. The ventilation, if it is given by bag and mask, it will go and inflate the stomach contents, and that stomach will again herniate into the lung side. Also, you can insert a nasogastric tube immediately to decompress the stomach from whatever contents are there, whatever the baby has swallowed when it was inside the womb. So decompress it with a nasogastric tube, then avoid bag and mask ventilation and instead intubate the patient so that you directly have a tube inside the trachea, and whatever oxygen and air you're giving, it is going directly to the lungs and not at all to the stomach. Following which, the pulmonary artery hypertension is stabilized. Now you know that after delivery there are several changes that take place in the pulmonary vasculature. The pulmonary pressure decreases significantly when it adjusts to the outer atmospheric pressure. So after delivery, we do not immediately. There have been studies that have shown that immediately shifting the baby to operation for operation in a case of CDH is not recommended anymore, and instead you wait for 2 to 3 days for the pulmonary artery hypertension to stabilize, to reduce as much as possible. It won't come to normal, but at least come as low as possible, and then you operate. Unfortunately, despite all operative interventions, the prognosis of the baby, the lifestyle that the baby will have when it grows up is going to be poor. It will have multiple recurrent respiratory infections. It will keep having respiratory distress, and hence the prognosis is generally going to be poor. A lot of babies that I have seen in my experience have even succumbed to sepsis and respiratory distress even before they underwent the surgery. Also, the surgical stress, it's a major surgery to fix the diaphragm. It is not an easy procedure, and a lot of babies succumb even post-operatively. So, not a great thing. It doesn't carry a great prognosis, but with improving pediatric surgery services, these rates are going to improve certainly. But the point for obstetricians over here are two things. One, to know what is LHR, that is the lung to head ratio, and secondly, to know what is FETO, that is fetal tracheal occlusion technique. I hope this video helped you understand congenital diaphragmatic hernia, and the next time you have a patient in your outpatient department with a scan that suggests the baby has CDH, you do not panic. You explain that these are all the complications, these are the options that we have, and ensure that you counsel the patient well. Thank you.